As your paper is very near, your FMG exam is very near. So we are here to discuss some of the important images that will, brush up your preparation and boost you like anything in your final exam. As I always get so many messages regarding the discussion of fundus images and retina images, because they are often asked, very important, very high yielding, and often there is some confusion regarding the fundus images. So let us begin with the fundus images today. All right. So before knowing the pathologies, first we will try to find out what is the normal fundus, and even before I will tell you what is fundus, because so many times I get this message that what is actually this fundus. So fundus is nothing but it is just the view of the retina that you view through the ophthalmoscope. So when you are having a view of posterior segment, that part of the retina that you are seeing, that is actually your fundus. Okay. Now, when you look at the retina, can you see a red glow? Often, you must have read this word that they say that a red glow is present. Now, some people may call it as yellowish reflex or a orangish reflex or a reddish glow. So, that actually changes from person to person, but yes, overall we have a bright reddish reflex that you see in the retina, and mind you, this is not due to retina. Okay. So, the neurosensory part of the retina is actually the transparent one, and what you are able to see, this reddish glow part is actually due to the choriocapillaries. So this is very important to understand that why we actually get this reddish reflex. It is due to the choriocapillaries. Okay. Now when I see whole of the retina, broadly I can divide it into two parts. So if you look at this part, one is the central part. This one will be your central part of the retina, and the other will be your peripheral part of the retina. Okay. Now, if you look at this central part of the retina, we have got two major things. One is your optic disc and another is your macula. So, you know that only one of the layers of the retina, okay, if I say this is your eyeball, so only one layer of the retina actually comes out to form this optic nerve. So when you see it from the front, this portion, okay, you will get a circular area. So that circular area is actually called as optic disc, or we can call it as optic nerve head. We can also call it as optic nerve head. So are you clear with what is optic disc and what is optic nerve head? And what happens if you look at the structure of this optic disc? Suppose this is your optic disc, okay. Here we also have a central hollow. So we also have a central hollow in between. Why? Because the one nerve fiber layer that is continuing to form the optic nerve, okay, so it is going something like this. So that thick rim, this thick rim is actually your neuroretinal rim. This is called as neuroretinal rim. This is the thickness of the nerve fiber layer, and the central area will be the hollow area through which no fibers are passing. So this will be called as the cup, while this peripheral area will be called as a disc. So this is your optic disc. And what is the normal CD ratio? Normal CD ratio. Now what do you mean by the CD ratio? That means the diameter of the cup upon the diameter of the disc. Diameter of the cup upon diameter of the disc. So if I compare this diameter of the cup in comparison to whole of the disc, it is just, it is just 3/10 parts, or it is 4/10 parts. That means if I divide whole of the disc into 10 parts, so cup will occupy only just the 3 parts or the 4 parts. So the CD ratio is 0.3 or it is 0.4. Therefore, the normal CD ratio that you get is 0.3 or 0.4. Okay, so this is about your physiological cup, your optic disc, and what is the diameter of this optic disc? It is 1.5 mm. 1.5 mm is the diameter. Now, in the center of this optic disc, we have got the blood vessels which are actually supplying this optic disc. So, these are the veins and the artery. So, it is the central retinal artery and the central retinal vein. If you look here, can you see two things here? We have got one this and one this. So, the darker one which has a broader caliber, the wider caliber will be your vein, and this one is your artery. Is this visible, this color? This is vein and this is the artery. Okay, always remember this. Now, if you look towards the temporal side, always remember that the optic disc is on the nasal side. So, the optic disc of my right eye will be towards the left side and the optic disc of my left eye will be towards the right side. While towards the temporal side, I have another important thing, and that is actually your macula. This is called as macula, and the full name will be macula lutea. Lutea actually has come from the word lutein, that means yellow. So, it is yellowish in color due to the presence of the pigments, and that is why it is called as a yellow spot, and the diameter of this is 5.5 mm. The diameter of this macula is 5.5 mm. Very important thing is that the macula will always lie on the temporal side. Means the macula of my right eye will be towards the right side and the macula of my left eye will be towards the left side. So, whichever side you are seeing the macula, it is that very eye. So, you can easily remember this. Okay. Now, what happens inside this macula? You have got another area which is called as the fovea centralis, and the diameter of this fovea centralis is again 1.5 mm, which is same as that of the optic disc. Now, it is this fovea centralis which is giving you the sharpest image of the object. So, whenever I talk about the most sensitive part of the retina where you get the sharpest image of the object, that is actually your fovea centralis, and obviously we have a reason for this. Why? Because this is one area, fovea centralis, where you have relatively more cones. Means you can say there are no rods there, relatively very less rods are there. It is densely packed with cones, and that is the reason why we get the sharpest image here. Now, just at the center of this fovea centralis, we have a thing which is called as the foveola. This is called as foveola, and the diameter of this foveola is again very less, that is just 0.35 mm, just 0.35 mm. So, this is the central area of the macula which is responsible for giving a shining reflex. So, I can say that whenever I am seeing a healthy macula, actually whenever I am seeing a healthy macula, I get this bright yellow reflex from the center of the macula called as the foveolar reflex. So, towards the nasal side in the central retina, we have the optic disc. Towards the temporal side, again in the central retina, we have the macula. And what is the distance between the two? If you look at this foveola from the optic disc margin, so yes, this distance is actually fixed, and this is 2 disc diameter. This distance is actually your 2 disc diameter. Now, you already know that 1 disc diameter is 1.5. So, 2 into 1.5 mm gives us actually 3 mm. So, this area gives me total of 3 mm. Now, rest of the area will be the peripheral retina. So, broadly speaking, we have a central retina, we have a peripheral retina. Central retina consists of more of cones. Peripheral retina consists of rods, and cones are for colorful vision. So, the central area, whenever we have optic disc abnormalities, we have macular lesions, we have problem of color vision. while the peripheral vision is by the rods. So that helps in the dim light. So whenever we have a problem with the periphery of the retina, rods are affected, we are going to get the night blindness sort of symptoms, because they are not helping us to see in the dim light. So I hope this first normal fundus is very clear. Okay. So see this is your central retina. This will be the nasal side where I am having this optic disc. This will be the nasal side, and this will be the temporal side of the eye, because here you are having the macula. Okay. Now, if you see the clinical macula, there is a thing called as clinical macula. Clinical macula means that when you see clinically, okay, you do not have exact, anatomical demarcation around the macula or around the fovea, but clinically we can actually differentiate the area which is between the fovea centralis and the macula into the areas which is nearer to the fovea and one area which is nearer to the macula. So one area which is nearer to the fovea is actually your parafoveal. This is nearer to the fovea centralis, and the area which is nearer to the macula is actually your perifoveal. Now, how can you easily remember here? We have got A and we have got I. So, A comes before I, because A comes before I. So, fovea first will be surrounded with the parafoveal, and then it will have I. That means then it is surrounded with the perifoveal, and then we have the macula. So, I have fovea, then I have parafoveal, then I have perifoveal, and then I have macula. Alright. This is your clinical. Now, why does I require this? I require this when I see clinically certain things, when I want to say whether it's a maculopathy or not, or whether it is clinically significant macular edema or not. I want to see exactly in which area these actually pathologies are lying. So, if they are immediately, around the fovea, that will be your parafoveal area, and if it is away from the fovea centralis and nearer to the macula, then that area will be called as perifoveal. Now, if you look as the diameter wise, so diameter wise we have got the fovea centralis, that is your 1.5 mm, then you have parafoveal, that is 2.5 mm, and then we have got the perifoveal, that is your 5.5 mm. So, you can remember it as parafoveal, perifoveal, and then macula 1.5, 2.5 and 5.5 is your total macula. Alright. Now, we come to the different layers of the retina. Now, when you come to different layers of the retina, first of all, we have to see that how these layers are starting and how they are going. So, we know that total we have got actually the 10 layers of the retina, right? Total we have got the 10 layers of the retina. Now, if you look at the different layers of the retina out to in from the outer side. So, from the outer side, it actually starts with the RPE layer. It actually starts with the RPE layer. RPE layer is actually the retinal pigment epithelium. So, it is this retinal pigment epithelium which is lying on the outer side of the retina. So, obviously, what is lying outside the retina? We have RCS complex. We have got R, C and S complex. So, we have retina, then we have a choroid, and then we have a sclera. So, actually the outermost layer of the retina will be in contact with the basal layer of the choroid, and that is why this RPE will be in contact with the Bruch's membrane of the choroid. So, this is in contact with the Bruch's membrane of the choroid. So, this will be your outermost layer of the retina, and an important thing is that it is this RPE layer which is actually the most resistant. This layer is most resistant to the radiations. This layer is actually most resistant to the radiations. Again, an important question often asked. Now, After this, we have got a neurosensory retina. Now, if you look at the retina, actually, broadly speaking, we have a retinal pigment epithelium and then we have got this broader layer. This broader layer is a neurosensory retina, and you know, because retina totally consists of 10 layers, so this neurosensory retina consists of 9 layers. So what happens, normally also we have a space between this RPE layer and this neurosensory retina, and this space actually is called as subretinal space. Now, because this space is a subretinal space lying there, we cannot leave any space empty. As you know, in our body, whenever we have a space, we have a fluid, right? So this space also contains a fluid, and that fluid is called as subretinal fluid. So two important things. One is, what is neurosensory retina? It contains 9 layers. Where do you have the subretinal space and where do you have the subretinal fluid? That is very, very clear. Now, if I talk about this neurosensory retina, then this actually starts from the layer of the photoreceptors. Now, what do you mean by photoreceptors? Photoreceptors means the rods as well as the cones. We have got the rods and cones, and you know that presently these rods and cones are the first order neurons. Okay, the rods and cones are now accepted as the first order neurons. So this layer of the photoreceptors actually contains what? If you see here, this layer of the photoreceptors contain these segments. Can you see these segments here? So towards the outer side, this is your outer segment, and towards the inner side, this will be your inner segment. So these are the segment which is present actually in the layer of the photoreceptors. We have got the outer segment and then we have got the inner segment. Now, as you move forward, we have got a limiting membrane. So this layer will be your external limiting membrane. So we have the RPE layer, then we have got the layer of photoreceptors. These layers contains the outer segment and the inner segment, and then we have got a external limiting membrane. Now, after that, we have got outer nuclear, outer plexiform, inner nuclear and inner plexiform. Now, obviously, if the nuclei are present on this outer side, can you see this layer? These are the nuclei which are present, these darker colored. These are actually the nuclei which are present. Now, because these nuclei are towards the outer side, so this will form the layer called as outer nuclear layer. Now, what does this outer nuclear layer contains? So, it is this rods and cones which are projecting in this layer. Therefore, I will say that it contains the nuclei of the rods and cones. So, they are projecting in the next layer. They contains the nuclei of the rods and cones, and finally we have got the synapse also. Now, still the rods and cones have not ended up, and they are going to the next layer and they are forming this synapse. Now, if you see here, on one hand, okay, on one hand of the synapse, I have got these rods and cones, and on the other hand, what I will have, because on one side I have rods and cones which are the first order neurons. So obviously, on the other side, I will have the second order neurons. Now, what are your second order neurons? It will be very, very easy for you to remember if you remember that what are your second order neurons. Rods and cones are your first order neurons. So second order neurons will be your bipolar cells. These will be your bipolar cells. So can you see here also we have got the nuclei. Now, though we have got other cells also, we have got some horizontal cells also, we have got amacrine cells also, we have got bipolar cells also. But for our practical purpose, you can remember that mainly these are the bipolar cells because their synapse is between the first order and second order. So obviously, the outer nuclear will contain the nuclei of rods and cones, and the inner nuclei will contain the nuclei of the bipolar cells. In between, we have got the synapse that is present in the outer plexiform layer. Now, as you move towards the inner plexiform layer, now can you see again we have got the synapse here. So in the inner plexiform layer, again we have synapse, and on one hand I have got the bipolar cells, which are your second order neurons. So obviously on the other side I will have the third order neurons. So now you know what are your third order neurons. The third order neurons are the ganglionic cells. So again it is very easy to remember that this synapse will be between the bipolar cells and the ganglionic cells. So ganglionic cells from here and the bipolar cells from here, they are synapsing and they are actually forming your inner plexiform layer. Then finally we will come to actually the layer of ganglionic cells. So when you reach to the layer of the ganglionic cells, which are your third order neurons, you will have the cells which are called as ganglionic cells, but still we just have the dendrites and axons are projecting in the next layer. So these axons are actually, can you see these axons are going? So these axons are going in the next layer. So what is this next layer? This next layer is your nerve fiber layer. So very conveniently now I can say that this nerve fiber layer contains the axons of the ganglionic cells. It contains the axons of the ganglionic cells. Now, if you remember the definition of glaucoma that I gave you, the multifactorial optic neuropathy characterized by retinal ganglionic cell death by apoptosis. So, why it was actually ganglionic cell death? Because it was a optic neuropathy. Optic nerve is formed by the nerve fiber layer, and nerve fiber layer contains the axons of the ganglionic cells, and that proves that why actually glaucoma is an optic neuropathy characterized by retinal ganglionic nerve cell death, and that cell death will take place by the apoptosis. After this nerve fiber layer, we have got the final layer. This will be your internal limiting membrane. Finally, we will have internal limiting membrane. So, easily you can remember the layers of the retina from out to in, and you can also remember what are the components and the type of cells which are present in the different layers. If you look at the histopathological section of the layers of the retina, then it looks something like this, and it goes similar to that only. If you look here, the outermost is again your pigment epithelium. This is your RPE layer. Then you have got the layer of photoreceptors. In the layer of photoreceptors, can you see we have got this as the outer segment, and then this is your inner segment, and then it is going to the nuclei. So you can easily see these are your nuclei, and therefore this will be your outer nuclear layer. Now, because these are the nuclei of rods and cones, they will synapse with the second order neurons. So you will have the plexiform layer here. So this is your synaptic layer, and then on the other hand we will have the second order neurons. The second order neurons will be your bipolar cells. So this contains the nuclei of the bipolar cells. On the other hand, this will contain the first order neurons, that is the nuclei of rods and cones. So remember it by first order, second order and third order, you will easily remember it. Then we have got the plexiform layer, because now these bipolar cells have to synapse with the third order, and the third order is your ganglionic cell. So this will be your ganglionic cell layer, and ultimately these axons of the ganglionic cells will be going in the nerve fiber layer, and nerve fiber layer will be finally having this internal limiting membrane. So even if you get this kind of thing, you can easily recognize what is actually the sequence of the different layers by your first order, then second order, and then third order neurons, right? Okay. Now if you see the blood retinal barrier, see like we have the blood brain barrier, similarly there is a thing called as blood retinal barrier. So every time you have some pathologies, there may be the breakage, there may be some breakdown of this blood retinal barrier. Now there are two blood retinal barrier, one is present on the outer side and one is present on the inner side. Now what is the outermost layer of the retina? RPE layer. So we have got tight junctions between the retinal pigment epithelial cells. So those tight junctions, if I show you this layer, okay, we have got the tight junctions here. So if this is your RPE layer, So we have got tight junctions which are not allowing the fluid to pass. So whenever you have got the breakdown of these tight junctions, like which takes place in cases of central serous retinopathy, we have got the CME, there will be collection of fluid. Similarly, the inner side is formed by the vascular endothelium. So this vascular endothelium which is present on the inner side is actually making your inner blood retinal barrier, and if this is breaking down, then this will be occurring in cases of the angiopathies, in cases of the diabetes, where we have a microangiopathy. So in cases of especially PDR, which is a proliferative diabetic retinopathy, you will have a breakdown of inner blood retinal barrier. So what is the outer blood retinal barrier, what is inner blood retinal barrier, and where they are breakdown, again are important things. So with this aspect, when you know the normal retina, the layers of retina, the blood retinal barriers, now some of the important pathologies of the retina. The first important thing is your Roth spots. Now Roth spots are actually important because they are found in a disease which is important in the medicine. So you can get an integrated question here. The Roth spots are found in the subacute bacterial endocarditis, subacute bacterial endocarditis, and this is one topic which is important in medicine, and then in pharma also, in patho also, and then in ophthalmology also. So obviously it is important for your examination as far as the integrated questions are concerned. Now why do we get these Roth spots? We get them due to the retinal hypoxia. So in the patients of the endocarditis, that is subacute bacterial endocarditis, we have got the retinal hypoxia, and due to this retinal hypoxia, we start getting these Roth spots. Now what are these Roth spots? Can you see? We have got a single Roth spot here. This is actually nothing but a superficial hemorrhage. This is nothing but a superficial hemorrhage, and there is one prominent thing here. Can you see? There is a whitish spot here in the center. So we have got a white spot in the center and we have got a superficial hemorrhage. So this whitish spot that you are getting in the center is actually a fibrin clot. It is actually a fibrin clot. So like these, we can have many Roth spots. Very, very important that whenever you are having the Roth spots, always look at the patient, and he may be a patient of subacute bacterial endocarditis, and these kind of patients, whenever are admitted in medicine ward, their fundus is always requested, and we are always getting fundus referral in order to see that the Roth spots are present or not. Okay. Now the second important thing, can you see the fundus here? But inside the fundus we are having something, a lot of blood here. You are able to see the lot of blood here. So what is actually this blood? This is the hemorrhage, and where it is present? Inside the fundus, that is the vitreous cavity. So this is actually your vitreous hemorrhage. So this condition is called as vitreous hemorrhage. Now whenever you are having a patient of sudden painless, whenever you are having a patient of sudden painless diminution of vision, one of the important DDs that you can keep in your mind is the vitreous hemorrhage. Now if you are having the vitreous hemorrhage, what are the different etiologies you can think of? So the first important thing is that the most common etiology of this is actually spontaneous. So if you are not getting any etiology in the question, don't worry, it could be a spontaneous vitreous hemorrhage, and this is followed by the trauma. We can also have the trauma. The most common one is your spontaneous, and this is followed by the trauma. You can have a history of trauma, you may not have a history of trauma. But if you are having a recurrent vitreous hemorrhage, if you are having a recurrent vitreous hemorrhage, then of course you have to search for some pathology. So if you are having a recurrent vitreous hemorrhage, what is the pathology that you have to search? Depends upon the age of the patient. So if this patient is young or if this patient is elderly. If this patient is young, you have to think about the Eales disease. Then you have to think about the Eales disease, which is occurring due to the hypersensitivity reaction to the tubercular proteins. But if this patient is an elderly patient, then the first thing that you have to think is actually the PDR, that is proliferative diabetic retinopathy, because you know the hallmark of this PDR is actually neovascularization, and when we have neovascularization, these vessels are very, very fragile, and because they are fragile, they will lead to the vitreous hemorrhage. So whenever you are having the B scan showing you absence of the red glow, because this hemorrhage will obstruct the red glow, you will have also the floaters. A very important thing that this patient will show me is the floaters. Floaters means black spots in front of the eye. Why? Because vitreous is gel-like, and due to this hemorrhage there will be clumps. So these clumps are seen as the floaters or the black spots. Obviously there will be absence of the red glow. You will have sudden painless diminution of vision. Think about the vitreous hemorrhage. Another important thing is that there will be no metamorphopsia. There will be no metamorphopsia. Now, what do you mean by metamorphopsia? Means distorted images. So, metamorphopsia actually is a feature of macular lesions. So, when I am thinking about CSR or CME or a macular hole or a macular degeneration, I will think about the metamorphopsia. But if I am not thinking about some macular pathology and I am thinking about some vitreous pathology, I do have the floaters, but I will not have the metamorphopsia. So again, you can get a question all except type. You will get sudden painless diminution of vision, you will get floaters, you will get the absence of red glow, but you will not get the metamorphopsia. All right. Now coming to the another important thing, can you see what it is? So let us try to see what are the things we are able to see. This is your pale retina. We are able to see the pale retina here, and here I am able to see a dark spot which is cherry color. So this is actually the cherry color spot which is seen towards the temporal side, because this is your optic disc. Okay, so that means I am seeing this cherry color spot towards the macula, in the center of macula. So this area is your fovea centralis. So that means retina is not getting the blood supply. It is a pale retina. So what could be there? It is a case of the CRAO. So this clearly is a case of CRAO. Now, though you can get a cherry red spot at many other places also, but here because you are having the pale retina also, milky white retina also. Why? Because due to the collection of the exudates, because you have collection of exudates in the ganglionic cell layer. And this ganglionic cell layer is actually absent in the fovea centralis. We have got lesser layers present in the fovea centralis. So what is happening? The choroid still shines through the fovea centralis. I was having a red glow in whole of the retina because choroid was shining in the retina. But now what is happening? All of that glow is covered by these exudates. But these exudate collection which is present in the ganglionic cell layer is not present in the fovea centralis, because this layer is absent there, and that is why it is the only place in the retina where choroid continues to shine through the fovea centralis, giving rise to the spot called as cherry red spot, giving rise to cherry red spot. Now, when you read this cherry red spot, you can't, go without discussing the DD of this cherry red spot. Always remember, cherry trees never grows tall in mud and sand. They never grow tall in mud and sand. So we have got CRAO, then we have got T for Tay-Sachs disease, then we have got N for Niemann-Pick disease, then we have got G is for the Gaucher disease, then we also have gangliosidosis, T for trauma. Now again, this is important. Many times it is asked in your examination also. Trauma happens to be asked many times. This trauma is actually the blunt trauma. Now what do you get in this blunt trauma? We get the macular edema, which is called as Berlin's edema. It is called as a macular edema, which is called as Berlin's edema, and this Berlin's edema again is a DD of your cherry red spot. Then apart from this, we have got mud. Mud means we have got metachromatic leukodystrophy, and then we also have this sand. Sand is actually your Sandhoff disease. Sandhoff disease. So there are so many places where you can get this cherry red spot depending upon the other signs and symptoms also that you are getting in the patient. Depending upon the age of the patient, you have to decide which cause it is. But certainly if they are telling you about the CRAO, the patient will be a male, mostly more than 50 years of age. You will get the risk factors, hypertension, you will get atherosclerosis, the most common site will be lamina cribrosa, and what you are going to give. So you are going to give your high flow oxygen. This is called as the carbol mixture, high flow oxygen or the carbol mixture, in order to cause the vasodilatation. So this will be your 95% oxygen along with 5% CO2. Again an important question, why I want to give 5% CO2? I want to give this 5% CO2 in order to maintain the respiratory drive. Otherwise respiratory center will go in depression. So I will give high flow oxygen. I will also do the ocular massaging. In order to dislodge the thrombus, we do the ocular massaging. We try to decrease the IOP at the earliest. We will give the acetazolamide, mannitol, and then we can also do the paracentesis. That means the aspiration of aqueous. So very, very important. CRAO, I think, is the ophthalmic emergency. So a very important cause of this cherry red spot. Alright. Now after this cherry red spot, next comes this. What is this? Oh my God, there are many hemorrhages. Can you see? There are so many hemorrhages which are actually present in the fundus. Whole of the fundus is actually filled with hemorrhages, and it looks as if somebody has squeezed the tomato, or there is, falling of the ketchup inside the fundus. So this is typically the splashed. This is your splash tomato appearance. So this is very, very typical splash tomato appearance. It is also called as the blood and thunder appearance or the ketchup sauce appearance. And where do you get it? This is actually found in the patients of CRVO, and more important than this, that it is found in CRVO, it is actually the ischemic variety of CRVO. See, CRVO, 75% of the cases we do not get ischemia. We have the collateral supply and anastomosis established. You do not get the symptoms. But in 25% of the cases, we have ischemia, we have VEGF, we have lot of VEGF, and due to the release of VEGF, we have lot of neovascularization, and lot of neovascularization means many hemorrhages, which gives you typical splash tomato appearance. So you should be able to differentiate between CRAO and the CRVO, and it is this ischemic variety of CRVO which is actually responsible for giving typical 100-day glaucoma. Again, a very important and often asked question. 100-day glaucoma is a kind of neovascular glaucoma which is found in the ischemic variety of CRVO, because it takes about 90 to 100 days for the development of this glaucoma. Alright, now going to the next one. Coming up to the next one is the two important retinopathies. One is your hypertension retinopathy and another is the diabetic retinopathy, and often these actually images are asked. So we know that in the Western world, hypertension and diabetes are increasing, and nowadays with the better technologies, the longevities, now patients are living with these retinopathy, these diseases for a long time. And because the people are living with these diseases for a long time, so they are developing the retinopathies. So what actually happens in a case of hypertension retinopathy. What happens in the hypertension retinopathy? So if a person whose BP is more than 140/90 for so many years will start showing the changes of hypertension retinopathy, and the first change will be your nasal angiospasm. Angio means the vessel and spasm means the attenuation, and nasal is the quadrant in which it is found. So the first thing that we start getting is the nasal angiospasm, and this nasal angiospasm will be directly proportional to the severity of hypertension. More is the hypertension, more is the severity you are getting. And slowly and gradually you start getting changes in the fundus. So what are the changes that we get? Can you see these hemorrhages? These are called as the flame shaped hemorrhages. So hemorrhages that we get is the flame shaped hemorrhages in the hypertension retinopathy, and they are a kind of superficial hemorrhages. Why they are called as superficial? Because they are just spreading horizontally, they are not going into the deeper layers, and that is why they are taking the shape of a flame, or they are taking the shape of a boat. Okay, so because they are present in just the superficial layer, that is your nerve fiber layer. Similarly, we have got another thing, that is exudates. Can you see these large fluffy things? These are actually your exudates, and these are called as soft exudates. These are called as soft exudates, and again they are present in the nerve fiber layer of the retina. Now, because these soft exudates are large, fluffy, yellowish white, which resemble the cotton balls, so they are also called as the cotton wool spots. So they are also called as the cotton wool spots. So superficial hemorrhages, flame shaped hemorrhages, soft exudates, or the cotton wool spots. Along with the attenuation, you can see the vessels are so much attenuated, very, very thin. Along with the retinal edema are very, very prominent changes that you are going to get in a patient of hypertension retinopathy. Now, how to differentiate these? How to differentiate these? We will have to see the other findings also. One important thing that you can also get in cases of the hypertension retinopathy, can you see this area is your optic disc, right? This is your optic disc. So towards the temporal side, that means this area will be the macula. Okay. Now, can you see the puckered appearance of the macula here? We are having a puckered appearance, or a fan-like appearance, or a star-like appearance. This is actually called as macular star. This is called as a macular star, and this macular star again can be a feature of malignant hypertension. Can be a feature of malignant hypertension, which is called as stage 4 hypertension. Why we have this macular star in the stage 4 hypertension or the malignant hypertension? Because it always shows you papilledema. Because it is always showing you papilledema. Now, papilledema is different from the optic neuritis. Optic neuritis is an active optic nerve disease, while papilledema, P for papilledema, P for passive. So, papilledema is a passive optic disc edema which is bilateral, which is due to the increased intracranial pressure. So, because of the stage 4 hypertension shows the papilledema, papilledema will show the macular star. Again, it's a feature of hypertension retinopathy. Okay. Now, coming up next, there are certain important signs that you get in cases of hypertension retinopathy, and they are with respect to AV crossing. So, what is that AV crossing? So, can you see here, this wider caliber will be your vein, and this lighter one is a artery, and you can see that this area, a vein and an artery, are crossing each other. So, this is actually called as AV crossing, because often we read about these signs and they say that it is distal to the AV crossing, at the AV crossing, or it is beneath the AV crossing, but we do not get to know what is actually a AV crossing. So, when we are getting the tapering of the veins, tapering means deflection. If I am getting the deflection of these veins with respect to these AV crossings, okay, then we have got the different signs of hypertension retinopathy. For example, let us take this one. Okay, if you see, we have got three important signs in the hypertension retinopathy. One is the Salus sign, then we have got the bonnet sign, and then we have got the gun sign. So Salus sign will be your at the AV crossing. It is at the AV crossing, means if the deflection of the vein is taking place just where a artery and a vein is crossing each other, that is called as Salus sign. Now the bonnet is always on the distal side of the car. So always remember, when it is distal to the AV crossing, can you see here we have got distal to the AV crossing. So here you have got a AV crossing. Can you see this area is your AV crossing? So when the deflection is taking place just at this AV crossing, then it is Salus sign. When it is taking place distal to the AV crossing, then it is called as the bonnet sign. And then we have a gun sign. So gun sign mein kya hai? It is perpendicular or right angle. So what will happen? A vein will be concealed beneath the artery. It is going beneath. This is called as gun sign. So we have got the Salus sign, we have got a bonnet sign, and we have got the gun sign. What do you mean by AV crossing and why they are different signs? Because they are present at different places. What does this reflect? We have tapering of the veins or the deflection of the veins. Okay. Now, after this, we come to what you called as the diabetic retinopathy. I think the two major killers of the retina are your hypertension and diabetes. Now, having seen the signs of hypertension retinopathy, now we come to the signs of diabetic retinopathy and we'll try to differentiate between the two. Now, first of all, try to understand that when we talk about the diabetic retinopathy is actually a microangiopathy. It is a microangiopathy. So basically it is affecting the smaller blood vessels. Now what are smaller blood vessels? We have arterioles, we have got venules, and we have capillaries. Now because they are affecting just the smallest of the vessels, so obviously the amount of the pathology will be maximum. When the pathology is maximum, you will have maximum release of the VEGF because it is causing maximum ischemia. So when it is causing maximum ischemia, that will release maximum VEGF, and when we have maximum VEGF, we will have maximum neovascularization. Okay, that is why neovascularization is actually the hallmark feature of the diabetic retinopathy, especially in the PDR form. Now, what is the first change that we get? The earliest change that we get in diabetic retinopathy is actually a microaneurysm. What is a microaneurysm? These are just the pinpoint hemorrhages, very small pinpoint hemorrhages are called as the microaneurysms. And if you go by the pathology, it is just the loss of the pericytes from the capillaries. When there is a loss of pericytes, there will be dilatation which is coming out something like this. So these dilatations from the capillaries are actually seen as the microaneurysms, which is actually the earliest finding. Because it is the earliest finding, so you are going to get in the NPDR stage, because NPDR or the non-proliferative stage is the earliest stage of the diabetic retinopathy. So if they are talking about the microaneurysms, the first thing that comes to your mind is the diabetic retinopathy. Alright, now if you see a typical fundus picture of this diabetic retinopathy, what are the things that you are going to see? Now let us try to see this and try to evaluate what are the things which are available here. So we have got something which are very small hemorrhages. What are these? These are actually your microaneurysms. Very small pinpoint hemorrhages are the microaneurysms. Then you are able to see that even we have got bigger than this. So these are your dot-like hemorrhages, and then we have got even bigger like this. These are called as the blots. So can you see we have got three sizes of hemorrhages, while in hypertension retinopathy I was just having a typical kind of hemorrhages which were horizontally spread, flame shaped, but here I am getting pinpoint also, then we are getting dots also, then we are getting blots also, because these are your deeper hemorrhages. So in hypertension retinopathy we have got the superficial hemorrhages, while in diabetic retinopathy we have deeper hemorrhages. You can remember D for D for diabetes, D for dots, D for deeper hemorrhages. The earliest feature is a microaneurysm, and then a very, very important thing is these exudates. Can you see these exudates? They are not the large and fluffy exudates that we were getting in cases of hypertension retinopathy. These are the small exudates. So these smaller exudates, which are actually, you know, yellowish in color. These are yellowish in color, they are waxy. These are called as hard exudates. So now I can say that when I am dealing with a case of NPDR, non-proliferative diabetic retinopathy, which is the earliest stage of diabetic retinopathy, I will have microaneurysms, I will have dots, I will have blots, and I will have hard exudates. Now the changes of the hypertension retinopathy were found only in the nerve fiber layer, but if you see here, we have got different layers involved. So how to learn that? So important thing is, remember the open. This is the mnemonic. You can easily remember that open actually opens the gate for the retinal diseases. So most of the retinal diseases are found in these two layers. One is your outer plexiform, means this one, and one is your inner nuclear, that is IN. So it is present actually in two layers. One is the outer plexiform and another is your inner nuclear. Now how to remember what is found in which layer? So one is your HOP. HOP means the hard exudates are found in the outer plexiform layer, and then you are left with IN. So the rest of the two things, that is your microaneurysms and your hemorrhages, are found in this inner nuclear layer. So very easily you can remember the open, then you have HOP, and what is left is in the inner nuclear layer. Okay, so this is your NPDR stage. Now try to differentiate between the two. Now you have seen them already. Can you see these? These are your large one, fluffy one. So these are your cotton wool spots, the soft exudates. Okay. On the other hand, if you look at these are your hard exudates. I am showing you again to show you the sharp contrast. Can you see the sharp contrast? These are your soft exudates, or the cotton wool spots, which are the larger one. On the other hand, these are your hard exudates, pale yellow, because these are actually the lipid deposits. So can you compare? On the other hand, the soft exudates are neuronal deposits. So they are comparatively whiter, larger in size, while hard exudates are yellowish in color, because these are lipids and the lipoprotein deposits. Okay. Now sometimes what happens, these hard exudates of the diabetic retinopathy are also present in a ring-like fashion. So when they are present in a ring-like fashion, this is called as succinate retinopathy. Then this is called as succinate retinopathy. It is nothing but the hard exudates which are present in this ring-like fashion. So whenever they are talking about the succinate retinopathy, you always have to think about the diabetes. Okay. Now next, what are the other things that we can see? So till we have the PDR, there are certain more changes also that can take place in NPDR that will make it as severe NPDR. So how we will come to know that this NPDR is going into severity and very soon it can go into PDR? So these are the changes which are IRMA and the venous beading. IRMA and the venous beading. Intraretinal microvascular abnormalities. Intraretinal means inside the retina, micro means small, vascular abnormalities. So these are actually the small AV shunts. These are actually the small AV shunts. Can you see these? Within the branches, they are bleeding. Then we can also have the venous changes. We can have the beaded like structure in the veins. And a very beautiful thing you can also see, a very beautiful thing that you can see is this. You can also see a looping. This is your 8-shape loop that you are getting in veins. This is called as venous looping. So you can see IRMA also, you can see venous looping, and this is how we can see the severity of the NPDR. Now when we are actually suspecting that this patient is having diabetes and development of diabetic retinopathy, what is the important investigation that we can do? So the important investigation that we can do is the fluorescein angiography. So you should know about this fluorescein angiography also. Can you see this? Okay, this area will be your optic disc. Then you can see the blood which is going in the major blood vessels, right? We have hypofluorescent areas and hyper, matlab two hai. One is your whitish areas and one is your darker area. So hyper is a white area where there is fluid, because of the fluid, because of the blood, dye is going there. So can you see these small areas? So these small areas that you can see, these are actually the pinpoint hemorrhages. So what are these actually? These are your microaneurysms. Then you can even see the AV shunts. Can you see here? This is showing you a small AV shunt. So this small AV shunt is actually the IRMA, intraretinal microvascular abnormality. So if I show you this angiography, you can clearly say it because there are small hemorrhages. So this is just the starting of the diabetic retinopathy. So this is your NPDR stage. Yes, because the AV shunt is also there, that means it is going into the severe variety of NPDR. Now having done this NPDR, the another important thing is your PDR. Now PDR never occurs abruptly. It always starts as NPDR and then goes into PDR. PDR is a proliferation. So proliferation of the fibrovascular tissue, that means there is actually neovascularization. So this is the word which is hallmark feature of the PDR, the neovascularization. And this neovascularization can take place exactly at the optic disc also. It can take place in the other places, means along the branches. So if you look here, here you are having this optic disc, and over the optic disc you are having this lacy pattern, the branching pattern. So this is neovascularization at the optic disc. So this is your NVD. This is your NVD. Now if you follow these vessels, can you see the abnormal vessels you are following, and again you are having some branching of the vessels at the terminal end. So this is your NVE. What is E? E is actually the elsewhere. This is elsewhere. So this is a stage where you are having the NVD and NVE. You are having the new vascularization. So I can say that this is the proliferative stage of diabetic retinopathy. So I think that's all for the today's session. Today we have learned some of the important details of the fundus. What is fundus? What is the normal anatomy of the fundus? What the central retina, the peripheral retina, the layers of the retina, then how to find out certain important pathologies, what is cherry red spots, splash tomato appearance, their DDs, the difference between CRAO, CRVO, and amongst all most important, how to differentiate and diagnose hypertension retinopathy and the diabetic retinopathy. In case of any doubt, you people can always post your doubts in the comment section. You can always ask your doubts, and keep on studying, be motivated, be safe, and happy ophthalmology.